Kibriam, just stay for a moment. Dr. Dinesh, please come for your presentation. Dr. Dinesh is past president of Punjab Ophthalmology.
Thank you, sir, and thank the AIOS for giving me this opportunity. I am presenting two cases of trauma, and one of these is a penetrating trauma and the other one is a blunt trauma. So I come from Ludhiana. The Birmingham eye trauma terminology system says there is a open globe injury or a closed globe injury. So we'll have one case each from both. Closed globe can be a contusion or a lamellar laceration, and an open globe can be a rupture, laceration, penetration, perforation, and a retained intraocular foreign body. So my first case is a boy. Video is not working. Came with the retained intraocular foreign body, and it was going through and through the cornea as well as rupturing the lens and lodged into the posterior side. So what we did was we made the interior entry wound into a CC. The corneal, of course, the cornea was stitched before, and even the posterior entry wound as a posterior CCC with the help of a cutter. So this was at the primary surgery level. Then we went ahead, did the pars plana vitrectomy, removed the foreign body with a hand roll technique, picked it up with a magnet and the forceps, and closed the case with the silicone oil. At 2 months interval, when we were going to remove the oil, in this situation, the silicone oil is already removed. So we separated out the two anterior as well as the posterior capsular remnants, or the posterior anterior and posterior CCCs, and implanted a hydrophilic lens with 4 haptic into the bag. So this lens has actually gone within the two anterior and posterior capsular rims and into the bag. And this patient has been following with us and has a best corrected visual acuity of 6, 12 and 6. This is now more than a 6 years follow-up. So the lesson we learn from here is that initial planning and the way we go ahead with surgery is very important in all cases of trauma actually. The second case is a 27-year-old male who presented to our center 1 month after a water jet injury. He was working in one of the Gulf countries, and he came for treatment after he probably got some first aid treatment there, and then realized that the cost of treatment is very high and he doesn't have a family there, so he came to Punjab again. On presentation, his left eye visual acuity was 660, which was not improving, and he had a post-traumatic cataract with more than 180-degree iridodialysis and a secondary glaucoma, which was 32 millimeters of mercury. So we operated him for phacoemulsification with IUL with repair of the iridodialysis.
Under local anesthesia, 23 gauge pars plana cannula was placed in infratemporal quadrant, 3 millimeter away from the limbus,
so
and was plugged.
Is to place a pars plana cannula.
Phaco ports were fashioned.
Although we didn't use it later on. Main port, side
2
ports.
superior capsular hooks were placed through 24 gauge needle openings to retract the large iridodialysis out of the field of phacoemulsification. CCC was fashioned and hydrodissection done. Phaco aspiration was done.
This was a routine phaco aspiration with IUL implantation.
Vitreous tag was cut using vitreous cutter, and anterior chamber was cleared of any vitreous. CTR was inserted to take care of superior zonulodialysis. Single piece, foldable, hydrophobic, acrylic IOL was dialed in position and IA was done to remove the cortical metal.
This is the phaco part.
Hoffman pocket was made superiorly. MVR entries were made opposite to Hoffman pocket to pass straight needles of 9O polypropylene suture. Rhydodialysis was stitched at 6 points using 3 polypropylene sutures. Straight needles of 9O polypropylene suture were passed through the iris by railroad technique using 30 gauge needle.